So hello, good morning, good afternoon, and good evening to all speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honorable guest from Germany, Professor Rene Chapot. Professor Chapot is the head of Department of Neurology at the Alfred Krupp Hospital in Eastern Germany. He is a world-renowned expert in the endovascular treatment of cerebrovascular diseases, including stroke, aneurysm, neurofistula, and arteriovenous malformation, and have been instrumental in the development of many concepts and techniques in treating this condition. He holds 2 device patents and authored more than 120 publications. Dr. Chapot has also authored numerous books and book chapters and have lectured internationally, often serving as faculty at various courses and symposia. We are extremely honored to have him today with us as a speaker of our webinar, and today he's going to talk on a critical analysis on the technique evolution of endovascular treatment of aneurysm. The speaker for the second session of today's webinar is our honorable guest from India, Professor Suresh Dugani. Professor Dugani is a senior consultant neurosurgeon at Sheikh Rupa Hospital, Hubil, Karnataka. He is also a professor in the neurosurgery at SDH Medical College, Karnataka. He's also a previous fellow of Fujita University, Japan. He has vast experience neurosurgeon who performed several complex neurosurgical procedures like over 1,200 aneurysm and 350 skull-based operation. He's also a noted author with several publications in various peer-reviewed journals. We are extremely honored to have him today at our webinar, and he'll be talking on Sylvian Fissure, Highway to the Skull-Base, My Journey to Various Skull-Based Pathologies. The chair for the first session today is our honored guest from the India, Professor Ani Karapurka. Professor Karapurka is the pioneer in the field of endovascular neurosurgery from India and a consultant neurosurgeon at the Bridge Candy Hospital, Mumbai. Professor Karapurka was also the past president of ASEAN Australasian Federation of Interventional and Therapeutic Neurology, AAFITN, and the Cerebrovascular Society of India. He has authored several chapters in many books and published numerous articles in many reputed peer-reviewed journals. We are extremely grateful and honored to have him to accept our invitation to chair the first session of today's webinar. The chair of the second session of today's webinar is our honorable faculty from UAE, Professor Wasim Aziz. Professor Aziz is the consultant neurosurgeon and chair of the neurosurgery at the Sheikh Shabot Medical City in Abu Dhabi. He has a vast experience as neurosurgeon over 23 years dealing with complex cerebral and spinal pathologies. Dr. Aziz is a distinguished professional in both academic and clinical settings and has previously served as consultant and head of Department of Neurosurgery at Mediclinic and as consultant neurosurgeon at Tawam Hospital. Dr. Aziz received his fellowship in skull-based surgery, endovascular surgery, and neuroanatomical study in Kyoto University in Japan. He then completed his research fellowship at the Barrow Neurological Institute in the United States of America in 2009 after receiving training at the Foundation A. Rothschild in France. Dr. Aziz was granted prestigious associate professor title in 2018 in the Department of Neurosurgery at the University of Alexandria. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato, I would like to welcome both our speakers and chairs and the audiences to this online platform of ACNS webinar. A warm welcome to our colleague from China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on WeChat channel. With that introduction, I would hand over this online podium to our first chair, Professor Ani Karapurka. Professor, please.
Thank you, Professor Liu and Professor Rajaputti and Yoko Kato for inviting me to chair this session. It's a very important session, and who better than Professor Rene Chapot to talk about the evolution of treatment of aneurysms over the last 3 decades now that we have been doing intervention for aneurysms using the GDC coils. Initially, it was a very crude system where we used to only treat these large, wide neck, giant aneurysms. And today we are treating more and more complex and more difficult aneurysms which one would not have imagined 20 years ago. So Professor Rene Chapot is one of the pioneers of many of these techniques that we use today routinely. In fact, I have learned a lot from him over the years, and we are very happy and very thankful to him for having accepted to give this talk. So over to you, Professor Shapoor.
Okay, hello, good evening. It's a real pleasure to be part of the course, and I'm very happy to be online with you today. On site is better, of course, but online already makes a lot of things possible. So I would like to thank the organizer for having me on board. And I suggest that we start now with the presentation, and I would like to share with you some thoughts on the evolution of treatment and what should be done, how. Because obviously, if we look within the last 30 years, we see that there's been important changes within the course of the years in the tools that were used. So the very first pioneers that dared to do some treatment used detachable balloons. And because they did so, today we're able to use a lot of other tools. So it seems heroic today if you look how hazardous it was, but it somehow worked. Then after the detachable balloons, the coils came in, that after the helix coils became the electrically detachable coils. And then at some point at the year 2000, stents appeared, followed by remodeling balloons. And the new revolution that came in, which is now about 15 years ago, are flow diverters. But not only flow diverters, but also bifurcation devices and even intrasaccular devices are available today. So this is a lot of devices. And today, difficult to say what we should do when we treat an aneurysm. Of course, forget the old things. Detachable balloons are not to be used today, but what should be the criteria? And if I look around what's going on, how publications are and what's being done, I see that there's a growing use of flow diverters, a growing use of intrasaccular, and a shrinkage in the use of the older devices such as coils and stents and other things. So maybe tomorrow is going to be much more flow diverters and intrasaccular, maybe exclusively, who knows? So what is good? What is bad? How should we evaluate this way? So what are the criteria of choice today for treatment to be done? And if we look worldwide, I think one of the most important criteria remains cost, which is not reflected by publications. Publications are rather tend to show the latest devices because there's something new to say. And of course, it's interesting because everybody wants to know what's new. But cost is a major limiting factor. And obviously, each new device is always a lot more expensive than the older devices. So when the coils came in, they were already extremely expensive. So price has been shrinking down. And the new devices now, if you look at the price of flow diverters, it's a lot of money, much more expensive than regular stents. And the intrasaccular are even much more expensive. So at some point, if the physician gets some percentage of the cost, it may be interesting. But for the expansion of a technique, cost cannot be the criteria why a device is to be used or not. So we should focus on what are the better results. And the best way to look at the good results is, in fact, to know what allows to avoid bleeding of an aneurysm. So if we would like to make a proper analysis, we should look at how often do patients bleed once they have been treated. So the incidence of SAH after treatment of an aneurysm. The problem is it's extremely complicated because the rupture rate of aneurysm is quite low. So the only studies that looked at the incidence of SAH was ISET. And ISET is 25 years ago now. And ISET showed some very significant results, that the risk of rebleeding of aneurysm is extremely low once they've been treated. But still, we're missing other studies because this requires a lot of patients, a long duration of follow-up, and of course, a lot of costs if you want to do it this way. So today, most studies are based on stability of occlusion, which becomes much more difficult to appreciate, and on complication rates, knowing that a lot of studies are based on self-evaluation of the results. And if I look at, for instance, at one study here, looking at the results 3 years after Webb, to look at the stability of the results after 3 years, if you look at the abstract, acceptable results, 84%, it's good. Definitely no reason not to use this. Even you should use this device because 84% is a lot of positive results. So how those good results were achieved? If you don't believe that your results are so good according to the classical evaluation characteristics, the first recipe is to change the evaluation method. So create a new classification. So in the Raymond scale classification, a small remnant is not a big drama, but is not a good result. A small remnant is classified according to Jean Raymond and Daniel Roy as grade 2. If you consider a small remnant as, well, not so bad, you turn it into an acceptable result. An acceptable result is subjectively a good result. So obviously, the Raymond scale is objective, not saying whether it's good or bad, but just saying there is a small remnant, whereas acceptable is a subjective statement. For instance, if you receive a glass of wine, what is the level of filling of the glass of wine which you would consider to be acceptable? Is it this one, or this one, or this one, or this one? I mean, each level of filling is acceptable. Of course, I would prefer the one on the right, but I think that acceptable is of no significance and should be avoided. So if we continue to look in this study, so if we turn stable with neck remnant and residual, it changes from the initial study. If we look into more of the details of this study, but I have nothing against this study or other studies, I just try to show you the tricks that I used to make results that are not so good look very good. And here you see, for instance, that patients who were retreated were not included in the analysis. Of course, they were not included because you could not say how was the Webb device after 3 years. But is there any doubt that the result was bad? If you have to retreat an aneurysm, that you're facing a major recanalization. So to exclude retreated patients is a nonsense. So if you look at the initial results with exclusion of the major recanalization, this is how the figures turn down. And a very good result of initially 84% comes down to 44%. 44% is not as good. So it's okay, but it's just important to know the figures the way they are. Additional points, if you know that with Webbs you only can treat aneurysms that are below 10 millimeters, knowing that the smaller aneurysms are the ones that recanalize less in compared to the large ones, this does not appear as being such a good result, knowing also that follow-up, as usually in this kind of studies, is available for a poor number of aneurysms. So the guidelines say all the ones you don't have for follow-up should be stated as bad. But if you would state those results as bad, then the results would be so horrible that you couldn't have it published. So we must be very careful in the interpretation and in the superficial aspect of the results, because quite often it's a bit less good than it seems. Is Contour better? I'm not sure. Contour is the latest device. Contour is even more easy than Webb because you don't have the problems of sizing. But already the first users know that the chance to have this little cap being completely inverted after some time is not so low. So please don't misunderstand me. I don't pretend that intrasaccular are always bad. I just want to have a clear idea of how good or how bad it is. So evaluation of the results is something which certainly is important. Another factor that counts into my practice each time I'm proposed a new device is whether I know if the new device is going to enlarge my indication or to shrink them. And if you look at both aneurysms here, on the left side, it's an MC aneurysm. On the right side, it's an ACOM. The ACOM aneurysm obviously looks like a saccular, quite gentle aneurysm where an intrasaccular device can easily be placed. But on the right side, no way. Both aneurysms are treated with coiling and balloon-assisted coiling, and it was possible for both. So why should I change if a new device reduces the indication of what I can do? Last criteria or further criteria to consider when you consider a new device or another device is the ease of use. And I have the impression that this has become the main criteria because there's a growing number of tools, because some tools are not so easy to use, but also because there's a growing number of physicians. ISET opened the door to endovascular treatment to a large community. Mr. Clean and stroke treatment even more enlarged the doors. And today we've got a very high number of physicians that are willing to do endovascular treatment. It's a very good thing. I'm absolutely open to this. But I think that the difficulty of doing treatment should not be underestimated. And the learning curve to use properly different devices is not short. This takes several years to reduce the amount of serious complications that are created by a physician. So we must be aware of this before we choose which device we can use. So ease of use, of course, if it's simple, to place a web or flow diverter needs almost no endovascular training if everything goes on well. But if it does not go on well, then you are really in trouble because you are in hard difficulty to help the patients. So it's fast. And only the problem sometimes is sizing, which is still quite minor problem. However, you have additional software that are sold to you, which make you believe that you cannot use any device without using additional software at additional costs. I'm not sure that this is so important. So let's look now specifically at bifurcation aneurysms. Within the last year, we saw an important development in so-called neck bridging devices. The goal of those neck bridging devices is to avoid one technical difficulty, which is a selective catheterization to the division branch. This may be challenging if the angle between the arteries is acute. If the vessel is straight, it's extremely easy. The more the angle is acute, the more it becomes difficult. And if it's more difficult, then the willingness to take a neck bridging device that avoids you to do so is quite important. So this was initiated by a device which is not existing anymore called Trispan that was on the market some 20, 25 years ago. But that was quite rapidly retrieved because the results were not so good. And then at some point it was replaced by the so-called waffle cone technique. I guess you know what a waffle cone technique is. It's initially a stent that should be placed from one end, from the distal artery to the aneurysm to the proximal, where somehow the flame stent displaced, moved inside the aneurysm, and somehow it was a little help to avoid having the coils protruding in the artery, and that's why someone called it the waffle cone technique. I'm not sure we should call it the waffle cone technique. Maybe we should rather call it the I did not place the stent correctly technique. But of course, why not? but it's not intended to do so. But since then, some devices such as this here, the pulse rider, is intended to be placed in the aneurysm, and this is the way it looks like. You get it here, and somehow you avoid protrusion of the coils outside. In fact, this is not exactly correct. It should rather be inside. And you see that this way it's possible indeed to treat some aneurysms with still some difficulties because there are a lot of markers. You're not sure how it works. Same thing is a piconus, where the stent indeed was developed with intention to be left in the artery before the aneurysm, with this aspect here to hold the coils. And here's an example where you have some markers. You see they're somehow blocking the neck, only partially. And then once the device is in place, some partial occlusion of the aneurysm is possible. You can see that the neck is still there, but somehow something has been done. Or you may use a device requiring access to the selective branch, such as this barrel stent, which has been ovalized so that once this enlarged stent is here, the coils can be held. Or even some new device, but look at the amount of markers. I mean, it seems to be a company of ants that are running here in the artery, and I'm not sure that the understanding is really so good. The Eclipse is a device which is trying to get on the market since 10 years, but it's difficult and it takes time. And few patients have been treated, but somehow it works. The idea is not bad. The idea is to have this placed on one side and then you push the other end to the other artery. Why not? This may bridge enough to hold coils or not coils, we don't really know. I mean, all this is quite interesting, but finally only limited to a very small amount of aneurysms treated like this. So we all more or less had the chance to play a little bit with it, but nobody really entered this in his practice. So I think that most of those devices are already on the point to be retrieved because in the end, not simple enough. So if today, one of the most devices to be used is flow diverter. And the flow diverter has enlarged its indication to a lot of situations. Initially, it was developed for giant aneurysms because in giant aneurysms, those aneurysms treated with coils, it's possible to place coils, but point one, you need a lot of coils. Point two, the occlusion is never stable. All those aneurysms always recanalize because the coil is compact. So as it's not enough, having a way to reorient the flow in the arteries is a brilliant idea. And that's why the regular stents have been modified at some point. The Leo with 16 wires was at some point modified to 48 wires. The initial name of the silk should be Leo 48, and then it was changed. And when it appeared that the ability for this to work quite well was important, the silk was the first flow diverter, then the silk was increased in price because of the high amount of coils to be used usually in those aneurysms. But then we're facing a progressive shift in indications. For instance, as the flow diverters work well, they've been enlarged from giant to large aneurysms and to medium-sized aneurysms and to small-sized aneurysms and even today to microblebs. And I'm always surprised to see in social networks when someone posts a picture saying, oh, I've got a patient with a bleeding. I don't see any aneurysm, but maybe here's a small irregularity. Isn't it an indication? And usually everybody goes on, yes, do on flow diverter. I mean, we know that there is an important range of patients with SAH where there is no aneurysm. Does it mean that all those patients must have a couple of flow diverters placed for each irregularity of a vessel wall? Probably not, because the chance of having a new SAH if you have no aneurysm is extremely low. So I'm wondering on the need to place a flow diverter in each aneurysm. So you can say any vessel irregularity may be a dissection that may justify a flow diversion. But there is no rationality to proceed like this. Of course, sidewall aneurysms are not well treated with coils. Fusiform are not well treated with coils. So this is a clear indication for flow diversion. But bifurcation aneurysms, I'm not sure that bifurcation aneurysms are such a good idea, because in MCA bifurcation aneurysms, the rate of occlusion of the artery, which is bridged by the flow diverter, is something between 30 and 40%. So placing a flow diverter is just easy. But if from the beginning you consider that you have a 30 to 40% risk of losing the side branch, then from my point of view, a clip is much better. What about thrombose or non-thrombosed aneurysm? I mean, a thrombosed aneurysm, how can you expect that the flow diverter will help, knowing that the goal of a flow diverter is to transform a non-thrombosed aneurysm into a thrombosed aneurysm? But it's not because an aneurysm is thrombosed that it's going to cure. Sometimes yes, sometimes the thrombus is still going on to evaluate, and there is an active phenomenon into lysis of the clot, reclot, and all this makes the aneurysm continuing to grow. So you see that there are so many growing indications for flow diversion that you can even wonder at some point if we should not preventively place a flow diverter in the aortic arch for every person to further prevent the development of aneurysm. I mean, at some point, why not to even more exaggerate? So today, one of the very frequent questions is how to treat this aneurysm. This is a typical good indication for probably a flow diverter, because you see that the aneurysm is not so small. Of course, you can coil it, but the chance for having some recanalization is there, and certainly it's a good indication for flow diverter, but it's also a good indication for a braided stent and regular coils. So in my opinion, the whole debate on flow diversion is not whether flow diverters are good or bad. Of course, flow diverters bring a lot of positive things, but how often should they be used? So should they be used in all indications? And in my opinion, there is an overuse of those devices. Of course, there are some specific concerns that we learned in the meantime. There is no indication for flow diversion in serpentine aneurysms. Serpentine aneurysm is something like this, where what you see as a lumen is not surrounded by endothelium. This is here a channel within a huge thrombus of a very large aneurysm. So of course you can place a flow diverter. This is the way it looks like. This is one of the patients we treated 15 years ago with our first flow diverters, believing it would always work. And 1 week later, it looks brilliant. But 3 months later, you see here some flow. And the paradox in those patients is that as evaluation is based on angiography, the angiography looks good or almost good. And this is stated as being minor, such as a result after 6 months. You see here only a minor amount of contrast within the aneurysm, which shows that the criteria to evaluate the treatment of flow diverger is just wrong. There won't be any compaction of coils because there are no coils. But what you must look at here is whether the aneurysm is shrinking, is same size, or growing. And if you look at the MR, between initial stage when it was treated and later on, there is no doubt that this thrombosed aneurysm is growing a lot. And that treatment that was achieved was not the good treatment. So we should stop to evaluate flow diverters only based on angiography, but we must look also at the results on MR. Otherwise, it's meaningless. And if you consider that all studies published today are purely based on angiographic evaluation, it means the poor level of significance of what is being published. other specificities for flow diverters. And please, again, don't misunderstand me. I place regularly flow diverters in aneurysms where I consider that it's a good indication, but not in each aneurysm. And we were struck by the fact that flow diverters may have some specific issues that we did not account with any other stent, which are problems after 1 year of placement of the stent. With all other stents existing on the market with, I would say, less metal, you may have any kind of problem, but once you reach a delay of 1 year, you reach a stability where nothing else happens. At least I never saw. And with flow diverters, we appear to see some issues after some time. So I treated this patient in 2010. This is June 2013. This is September 16. You see here both ICA. You see the ICAs are open. And after September 16, 2 months later, he came in with an acute blindness of the left eye. It was the left ICA here, the left ICA that you can see. And 2 months later, he just occluded his left ICA. So the fact that you may have delayed occlusion is something which is not so rare. We have around 15 patients where we had occlusions between 2 and 13 years after implantation, which is a lot. Bifurcation aneurysms. If there's one take-home message here is please don't put flow diverters in bifurcation aneurysms. This cannot be a solution that works. There are too many side branches. And let me share this patient here that was treated in 2005 with Y stenting. And 6 years later, 2011, you see that despite both neuroforms, you can recognize the neuroforms here on both ends with here the 8 markers. You see that the mass of coil is enlarged a lot. And because of this, believing that flow diverters would cure everything, I placed a flow diverter here in June 2011. And I placed even several repeatedly in several sessions because it was not cured. And here it looks quite good. But you see that some months later, it's even worse. You have a major recanalization. You've got an important inflow in this aneurysm, despite the fact that it had been retreated 3 times with 3 layers of flow diversion. So adding flow diversions is not a solution. So please compare the pictures on the left and on the right. On the left is after 3 flow diverters and 1 or 2 years later. On the right is just before placing the flow diverters. You can see on both sides that you have both SCAs. You have here both PCAs. But before treatment was initiated, you could see just here the right PCA, and you hardly could see the left PCA. And that's quite striking. Look here, this patient initially, before we treated him, had no PCOM, and he progressively developed a PCOM. Here's a PCOM that developed with time to fill in the left PCA, but still, I go back to previous slides, you have some flow in this P1 segment, which is a very minor flow, but which is a flow that is keeping the aneurysm patent. And because of this persistence of flow to the PCA, we speculated that this was the reason for this aneurysm to continue to grow. So this was our hypothesis. We went through the ICA, through the PCOM to the left P1, and we occluded the left P1 with coils, as you can see here. And as soon as it was done, the aneurysm shrunk down. You can see that 2 years later after this coiling, the aneurysm has no flow, residual flow left. This is now 3 years follow-up. And if you look at the MR, this is the MR at day where we did the treatment with occlusion of the left PCA. And this is 2 and 3 years follow-up. Look how much edema was in the brainstem, which is completely resolved. look how diseased the brainstem was because of this further growth of the aneurysm, which then stopped to growth and patient turned back to normal. The reason for this was the remaining flow in the side branch bridged by the flow diverter. So sometimes you're lucky, sometimes the flow diverter may occlude the side branch and anastomosis develop, but sometimes you're not. It's purely random. Can we do a treatment which is purely random? In my opinion, no. This should not be done. Okay, let me move forward to another situation. So what to do in those patients where the recanalization is sometimes, again, changed as good result? When you have results that are not good, as I said previously, change the classification. And this is another classification that has been appearing since flow diverters are on the market, where you see this aneurysm here, which is here on the inferior division branch of the MCA. A flow diverter has been placed in the superior branch. 1 year later, the aneurysm is still there. If you look this on a very positive aspect, you'd say maybe it's a bit smaller, but after 5 years it's still there. After 7 years it's still there. According to this new classification, it's a remodeling class 5 occlusion. I don't know what it means, but some persons will consider that this is a good result. I absolutely disagree with this type of statements, and I don't think that this is the way those aneurysms should be considered. So we have an increased number of devices, an increased number of implants, but we must not forget that adding the different devices may lead to dysfunction of those because just simply they cannot expand properly. And I was struck also by this patient here that I treated a couple of years ago after it had been treated previously by some person that made a really good job, but that probably mixed a bit too much of devices. There was initially an SAH for this basilar tip, and you can see that it has been coiled properly, but unfortunately 9 months later was a very important recanalization. So when this recanalization was there, same physician did another treatment and made a T-stenting with the first stent here, another stent there, first here, second there, additional coils, with again a result which I think is angiographically absolutely good. But again, 6 months later, major recanalization, where a new embolization was done. And at time, 2 webs were placed. Maybe you can see the tip of the webs here and there, and another stent was added. And guess what? What happened after? Again, a massive recanalization. So how can it be that this aneurysm that was treated by so numerous devices, so numerous technique, just keeps on growing? The answer is given by the cone beam CT. If you look at the cone beam CT, the device that was initially used, I forgot to mention, was a P-conus. The P-conus is to be seen here, preventing the stents to properly expand. If you look at AP, you don't see it. But if you look at laterally, you can see that the stents that were placed just could not expand. And what finally makes stent being efficient, it's the fact that when they're in contact with the vessel wall, they implant in the vessel wall, which cannot further distend, causing further growth of the aneurysm. So for me, if I see the amount of material here, it's just like these rivers. There's too much rubbish inside, too much material, which make all the things go wrong. Treating this patient then was a real pain. At this stage, I had to find something. I had to use coronary balloons to put different coronary stents first to break the devices inside, and then to put 2 kissing flow diverters. And once kissing flow diverters, parallel flow diverters were placed, which were properly expanded, then we could obtain something that was stable and that remained stable at 4 months and at 5 years. So obviously, we must be cautious because the increasing amount of devices is a problem. So what to do? This patient here, he has a diffuse ectasia, the left ICA that was discovered a few years ago, and for which he got a surgical occlusion of the left ICA because of good circle of Willis. And this is February 2016. September 18, you see that the basilar starts to enlarge. April 19, December 19, January 20, he's got a huge growth of this aneurysm. Here is the angio we did with the right ICA and the basilar aneurysm with an absolutely huge aneurysm, where the question is raised now what to do on this new occurrence of an aneurysm. And can it be treated with flow diverters? The answer is potentially, but it's point one tricky because many flow diverters must be placed on a telescopic manner. It is dangerous because there is a significant risk of hemorrhage to occur when those large unthrombosed aneurysms are treated with flow diverters. So we wondered what could be the best solution. And third, it's of course very expensive with all those flow diverters. This is when he came to our institution, it had grown even more. You can see it here. So no treatment, he's too young, he's less than 20, something must be done. Flow diverters, of course, but how good is it? Or test occlusion or stent coils. We opted for a test occlusion and found out that even when the basilar was occluded and the left ICA was missing, he had very good collaterals and everything could occur from the right ICA. Of course, on the long term, we have concerns in doing so, but this is finally the therapy we did because it was possible by inflating the balloon in the aneurysm to have just a very short length of coils in both vertebral arteries. And this enables this aneurysm to thrombose and to shrink and disappear without clinical consequences. So just to remember, I don't want to sound old-fashioned, but in large and giant or fusiform aneurysms, there is a publication done quite recently that shows that there is no mortality in patients where an occlusion of the parent artery is being done after parent test occlusion. The mortality of treating those aneurysms was very large, that are very large and non-thrombosed is not low. We have been seeing many of those patients bleeding or having serious ischemic complications. So the mortality is zero, the morbidity is very low, and of course is less fancy. It's more elegant to find a way to keep the artery patent, but it does not mean that it's a lesser good method. So what about this patient here? I want to share this with him because it was an atypical presentation of this basilar aneurysm. There was an acute onset with a ischemic onset in this patient with this basilar aneurysm, where if you look at the angio, you may see the aneurysm, which is mostly thrombosed, but angiographically, almost nothing was to be seen. But this patient had symptoms of occlusion of perforators. That's why we somehow tried to dislodge the clot with 2 centrifugers. We managed to reopen partially, and we left the patient under integralin. And under integralin, the patient was quite good, but we saw that after a while, the basilar was getting again stenotic. Patient survival was not so bad clinically. So we decided that we would add a stent. And the stent here is a braided stent. We placed 2 stents, making sure that we had a proper wall position. And the patient recovered clinically quite well. Here's a 5 months follow-up. And you can see that there is significant ischemia that occurred initially, but the aneurysm did not continue to grow. And here's a 1-year follow-up. And here's a 10 years follow-up. And on the 10 years follow-up, we realized that something new is developing. If you look here, beyond the stent, you see that there's something enlarging that we did not see before. Do you see this part here? If I go back, how it was before, after 1 year, it was faintly irregular. I promise we bridged the aneurysm. So this is just to give the message that even if treatment with stents can be good, and even if we control the aneurysm that was initially treated, because here these aneurysms did not continue to grow, it even shrunk, but we had a new aneurysm that developed after 10 years. This is a new aneurysm that developed, and to prevent further distension, we added another stent. And this is now the follow-up after 11 years and after 12 years. So even if we do some specific treatment on aneurysms, and even if the flow diverters or braided stents work, I think that we must be aware to be able to keep an eye on what's going on with time, because nobody's really aware of what can it be. And we have not only this patient, I don't want to show all, but we have several patients in whom we could see some similar evolutions. So I think I've been talking for 40 minutes. Do I have more time, or should I conclude now, as you prefer? How much time do I have for the topic?
Yeah,
You have
5 minutes.
Sorry.
I have 5 more minutes. Okay. So I know that a lot of you that are listening today have been trained in open surgery. So I want to add a couple of words on MC aneurysms, because MC aneurysms are very well accessible to surgery, where clip is a very good treatment, and embolization is something which is not easy for MCA. It's absolutely feasible, and I treat a lot of MC aneurysms, but it requires specific attention because the arteries are smaller, so there is a higher ischemic risk, and the access to the small arteries with large catheters is not so well. So we must take care. And of course, fusiform aneurysms are good to be treated with flow diverters when they are not too large. And this is here, this patient, where how to treat him. I mean, we're very happy to have flow diverters here. They were placed after doing some PTA and then some telescopic flow diversion, allowing to obtain these results. We had no ischemia despite the lenticular striates, but due to the fact that most of the lenticular striates were distal to that disease segment. Here's a 3 months follow-up, some stenosis here. So we did an additional treatment, some more PTA. And then here's a further control where you see that at some point we obtained a cure of the aneurysm with the very good conditions. Or for recanalized aneurysms, those kinds of aneurysms here where treatment were done with coils, but you see there's a narrowed segment here. These are very good indication with a flow diverter. The flow diverter is placed in M1, making sure that it's properly open, and look, after 6 months, the result is brilliant here. The aneurysm has shrunk in size and the aneurysm is cured. So these are indications, in my opinion, but not bifurcation aneurysms. And in bifurcation aneurysms, I think that using some specific devices here, such as here, this kind of device that are already J-shaped, allow to get access. Let me share a video where you may see that aneurysm here, where you can see where a device is being brought in. And when the device is being brought in, I mean, the microcatheter, because of the pre-shape of the microcatheter, it spontaneously orients to the side branch, and it makes access to the side branch extremely simple. And once it is done, then you can treat this aneurysm with balloon or stent assisted, whatever you prefer, in order to cure this aneurysm. So there are techniques enabling to do so, and I strongly believe that this is something important to know and to do. Knowing the fact, for instance, that when a remodeling balloon is being used, the remodeling balloon allows to understand what you do. It allows to see, for instance, at some point when the coils are superimposing on the balloon, that maybe the coils are not inside the parent artery, but the working projection that is being used is wrong. And by changing the working projection, if another working projection is found where the coils are not over projecting on the balloon, you find it well. So here's an example of a patient we just controlled recently of this MCA, which looks quite simple, but here you don't realize that there is an artery. I put a balloon in the MCA to demonstrate that this is a little side branch, a temporal artery, but we're on the left side, so it's important in this right-handed person, which arises from the aneurysm. So while treated with balloons, coils, this was the treatment. We added even a drop of onyx, some drops of onyx. You see that the side branch has been has been preserved. Stent was added here because of the onyx. There were some drops of onyx in the parent artery, and this is a follow-up after 14 years. We just controlled her. This is the side branch which is there. Or another way to use stents is in these kind of patients here where the angle is very tight, as you can see on this picture. You may place a stent by having what we call a C stenting, which means that the stent is being placed from here, and then you push this end to the other side, from one MCA branch to the other MCA branch. And this allows to obtain a perfect coverage of the neck. So definitely, there is a technical evolution, which is important. It's very good to have an increased amount of tools. However, the ease of use, which is often one of the major points which is brought in, should not be the main element of choice. And from this point of view, I would say that overuse of flow diversion should be avoided. It's not because it's easy that it's so good. And even if there's a lot of literature claiming that each device allows to have fantastic results, there are some significant bias in the evaluation of the devices. So the best way to know is to have time to look after several years, but as there is a permanent technological change, usually when we have the follow-up of 5 to 10 years, the device itself may have changed. So I'm concerned on the evolution of endovascular treatment. And for me, either endovascular treatment is good with significant stable result with time. And then this is the way it should be done, but this requires several years. And it's not 6 months, it's not 1 year, it's at least 3 to 5 years of training to obtain proper results. Otherwise, poor endovascular results will favor the redevelopment of clipping. Thank you.
Thank you, Professor Chapeau. That was a wonderful talk. And, you have shown us when and how and when not, what not. Everything has been, I think, made very clear. Let us take a couple of questions first. There is one that I can see here from Harshad Parekh. He's from Bombay, he's a neurosurgeon. Does the artery arising from the neck or fundus of aneurysm get blocked if a flow diverter is placed across it? Would Professor Chapeau please answer that?
Yes.
Does the artery arising from neck or fundus of aneurysm get blocked?
We don't know. Quite either the artery occludes, and quite often it's a progressive occlusion, which means that it's a silent occlusion with a cure of the aneurysm. But is it good to do a treatment where you intentionally occlude a side branch? My opinion is no. And so occlusion occurs in 30 to 40% of flow diverters induced bifurcation aneurysms. Or if it does not occlude, then the chance for the aneurysm to still being kept alive because of flow getting to both bifurcation arteries is high, and then I don't know about the quality of the results.
Thank you.
Can I?
If the artery gets occluded over time, does it still lead to neurological deficit?
No, it's silent. There is no stroke. So some physicians consider it's a good result. I don't know if it's the goal of our treatment to promote occlusion of side branches. My opinion is no. So I would say this should not be done. But I know that there are various opinions to this.
Thank you so much. That was very clear.
Yes.
There's one more question. Let's go to the second question, then we'll go on to what is your advice of fusiform dilatation of arteries or aneurysms?
That's
That is the second question. Fusiform.
That's a very good point. I think that fusiform aneurysms are just like tumors. And today's advice is to say, wait for it to become symptomatic. As if we would wait for a small tumor to become large. The larger the aneurysm, the less any treatment works. If we treat these aneurysms at a quite early stage, and there are some braided stents that have been developed and that have been even enlarged at our request to be as much as 10 millimeters. Whenever there is a fusiform enlargement of the basilar up to 10 millimeters, then we have devices that that correspond to the size that can hold the vessel wall to prevent further distension. And I would not be surprised. This is quite new. So of course we need the follow-up, but we've been doing this with other devices less large in the future. And by sure, we can say that any braided stent, whether braided or so-called flow diverter, are efficient in the small aneurysms. So smaller the aneurysms, the more it's efficient. So today we have no tool for the extremely large aneurysms. So I believe that probably we must.
Wonderful critical analysis of the endovascular procedure. Really, it shows a lot of insight into the problem, into the process of endovascular treatment of this aneurysms. Now, see, as you rightly mentioned, the ISAT took away the clipping of aneurysms, surgeries. But unfortunately, the follow-up of this ISAT study was very short. And we did look into the long-term outcome of these aneurysms, and you did mention that. Now we have various studies in 2016, 2018, 2019. The studies are coming up with the recurrence of aneurysms up to 30%. Rebleed chances up to 20%, growth of aneurysms up to 22%. Now, what is your opinion on this? Number one. Number two, second question is that the newer devices, what you showed us and what we have been using. Now, see, the aneurysm interventional treatment, endovascular treatment is available on this planet as of now only to about 30 to 35% of the population on this planet. Still 60% to 65% of the population on this planet, it's not available due to various reasons like cost, human resources, infrastructure, and all that. Now, this second question is that is this newer devices what are being used in the West and few countries in the East going to add further to the cost of the treatment and take away this modality away from the common man and make us to go back to the surgical intervention in majority of these cases?
So I think these are two very good points. I think that feasibility of treatment of an aneurysm today is given by many tools. The problem is not whether it's feasible, but whether it's stable. And to obtain a stable result is something which requires a lot of effort. It's not simple. It's something which requires a lot of work So a lot of persons are doing endovascular procedures with various backgrounds, and I think that this is an open field. So I encourage persons from different backgrounds to do so, but I encourage also to keep enough time in learning and doing the practice, and to do a proper endovascular treatment requires a lot of years. Otherwise, it does not work, and the result, something is being done, but the result will not be good
Very
on the
good.
long. Concerning the availability of the new devices, I fully agree. I'm very reluctant. Most of the new devices are developed to make the ease of use higher, but from what I see, the stability is quite poor. Prices are extremely important, so I'm not supporting this evolution. And I did not bring most of the new devices in my practice just because the stability is given is not at the level of the expectation. But
Thank
on the
you.
other hand, I can say that we do a lot of efforts. We use a combination of balloons, of hydrocoils, we put braided stents. If it's done this way, our stability rates are extremely high. And at 90% after 10 years, because we also do the efforts to follow the.
Okay. Thank you, Professor. Thank you very much.
Dr. Karapurkar.
Mr. Mathuria
Yes,
has
sir.
a comment or a question. I don't know. Go ahead.
Yes, sir.
Mathuria.
There is one comment and one question. The comment is that it's unfortunate that we could not develop evolution in the aneurysm clips as much as the endovascular people, including you, could develop. Number one. Say, I pay lots of regards to Professor Jua Harnesnimi, who came up with the Bickesy's detachable cam for the giant thick-walled aneurysms. Beyond that, we don't have anything much, and the booster clips as well. But the endovascular devices which have developed are plenty. There is no doubt about it. That's what is the comment. We should come up with something new in the neurosurgery to clip the aneurysms of all sorts. There is no doubt that the clipping of aneurysms is far better than the coiling if it can be achieved safely with the lesser complications than the endovascular techniques. I think Dr. Karapurkar will agree with me. Being a new, the question is, Professor, the question is that, say, what you will advise for an aneurysm which is partially thrombosed, what you will advise for an aneurysm which is partially calcified. Are these amenable to the endovascular techniques? If yes, then what?
Thank you, Professor Mathuria. Professor Chapo, could you answer this question? Partially thrombosed, partially calcified.
Absolutely. You've just been pointing on the limitation of endovascular treatment and the limitation of flow diverters, such as I did just before. So I fully agree that those are situations where endovascular is not good. But on the other hand, you see that that time is going on, that if you look at today's generation of persons learning, all persons learning invest more time in doing endovascular. And who is able to do a good clipping, the amount of persons able to do so is automatically shrinking. So we must also be aware of this. And I don't prevent anybody to place clips, it's good, but we see that persons that do both clipping and endovascular treatment very often themselves prefer to do and to place endovascular devices. So my aim of the message is if you do so, make sure that the endovascular devices that are placed are properly placed, that is not something which is only easy and which will not give a stable result, because in the end, this is one of the key points in the goal of a treatment is to have a stable, to avoid complications, but to have something which is stable with time.
Thank you, everyone. Professor Bogani.
Thank you, sir. So nice.
And of course, Professor Chapo for a wonderful talk. you have gone through the whole gamut of what we can do and the complications and the problems that we face with difficult aneurysms. And I think most of us agree that the middle cerebral artery aneurysms are best treated by clipping. I think time is up for us. So thank you so much, everyone. And let me take you back to Professor Liu.
Professor Wasim, you want to ask a question?
Yes, just one small question about the blister aneurysms. Professor Chabot said that sometimes irregularity in the visual wall doesn't indicate that this should be treated. But how you can differentiate this is a blister aneurysms or just an irregularity? Because blister aneurysms are very, very like dangerous aneurysms, can rebleed. So how you can fine tune and differentiate?
Very true. Very true.
I think it's a very good point. This is what that's why I mentioned it. I think we have no idea today to have a clear criteria, and the consequence of this is there's an overuse and overplacement of a flow diverter for each irregularity, claiming that it's a blister. I believe that we should have some angiographic evolution in the appearance before we say this is something abnormal. If we just face an irregularity from first angio, I would remain very cautious, and I think making some further follow-up to have an objective change should be a criterion.
But if the patient presents with subarachnoid hemorrhage and there is this irregularity,
the answer will always be subjective. I fear.
May I ask one short question, Professor? There are growing evidence to show that the growth of aneurysm due to vasa vasorum. Do you think that endovascularly there's a way to treat this, Professor, in the future?
There's been a wonderful case report by a colleague from Japan who made a fabulous demonstration that getting selective access enables to clear the problem of flow diverter. Very interesting of this aneurysm that he treated, which was a thrombosed aneurysm. I was amazed by the range of persons that saw his case that were willing to place a flow diverter, which made absolutely no sense because the aneurysm was already thrombosed. I still believe that it's something which is difficult because it's really small, so we need further improvement in the technology. And I would have been afraid, from my point of view, to be sure that it's a vasa-vasorum and not a perforator. So I think he's been extremely brave and tough to do so. And I fear that if there's an enlargement of the indication to do so, we'll have a certain number of patients which perforators will be embolized with dramatic consequences. So certainly something to be explored, a great concept and idea, but if it would have been easy, it would have been already done for a long time.
Thank you, Professor. Thank you for a very nice presentation and great discussion. Thank you, Professor Anil, for chairing this session. So we close this first session, and I would like to call upon Professor Wasim to call our second speaker. Thank you.
Professor Liu, for this opportunity, and thanks to Dr. Kato for allowing me to do this. Of course, Professor Suresh is a very well-known neurosurgeon. I know him from his very good techniques in neurosurgery, from his YouTube channel. I watched his surgeries several times, and I know how much microsurgical techniques play an important role for having a good and excellent results for his cases. So Professor Suresh today will speak to us about the Sylvian Fissure, the importance of Sylvian Fissure to reach the skull base and treat various neurosurgical problems through the anatomy of the Sylvian Fissure. Please, Professor Suresh.
Thank you. Thank you, Professor Wasim. Professor Rajakutti, Dr. Bois Sugliu, Professor Rene Chapos, Professor Anil Karapurkar sir, and Professor Wasim Azim, and the ACNS team. Indeed, it's a great honor and pleasure and privilege to participate in this excellent scientific meeting and share and learn from each other. Thank you very much for the opportunity. So as Professor Wasim mentioned, I thought I'll share with you a few of our work and experience in the management of microsurgical problems of the skull base. As neurosurgeons, we are called upon to treat in our day-to-day work a very complex problems. The topic I thought I'll share with you is Sylvian Fissure, Highway to Skull Base, and my journey over last 33 years treating these various problems. I bring greetings to you from India or South India, from Regional International Neurosciences Center, Hubli Dharwad. Historically, for the first time in 1600, Fabric Aquadempte identified the lateral surface of the fissure. 1610, Caspar Bartholin described it as a lateral sulcus. 1663, Francis Sylvius wrote a thesis and book, and since then, this location has been named after him as Sylvian Fissure. But the modern understanding of Sylvian Fissure was given by Professor Yasargil, 1980s, microsurgical anatomy, dissection types, and approaches, what we all follow till today in our day-to-day work. It is a CSF-filled arachnoid space anterolateral to the lateral part of the brain, and this space connects surface of the brain to deep centers of the brain and skull base. Opening this space during surgery gives wide, safe access to the deeper vital neurovascular structures and pathologies we'll see a little later, helps in comprehensive management of anterior, mid, and posterior skull base various pathologies. A brief anatomy, a brief embryology, very brief to know the development of this is identified 12 to 14 weeks of gestation as a small shallow depression on the lateral surface of the skull base. And it is formed by the convergence of frontal, parietal, and temporal lobes over the insula. The difference in the pattern of migration between these four lobules gives origin to the Sylvian fissure. The cells of insula originate from the pallial or subpallial boundary and migrate around the basal ganglia in an oblique migration pattern. The cells of frontal, parietal, and temporal lobes originate in the ventricular, subventricular zone and migrate in a radial pattern. And this radial pattern of migration creates gyri of the brain. These are the various developmental stages of the Sylvian fissure, starting as early as 13th week of gestation and keeps growing till the baby is born. These are the brains taken out in intrauterine aborted fetuses, and the depiction and showing of the Sylvian fissure. Coming to the microsurgical understanding and anatomy of this very important compartment is that it has three spaces. One is the deep superficial opercular compartment. Second one, deep opercular compartment. Third, cisternal compartment. Three important. Diagrammatically, this is superficial, which we see on the surface of the brain. This continues in the middle part of the brain, in the temporal, between the temporal and frontal lobes. And third is deeply placed in the paramedian or midline into the supracellular, paracellular locations. So superficial opercular compartment is the most superficial compartment of the Sylvian fissure. It is located between the outer arachnoidal membrane, spanning the frontoparietal and temporal banks of the fissure. Most superficially, this is the location, and the lateral Sylvian membrane running between the opercular, just deep to the superficial Sylvian veins. This is the membrane. Opening this outer membrane gives an opening and access to this Sylvian fissure. Superficial opercular compartment, that's a surface compartment, contains superficial Sylvian vein, M3 and M4 branches of middle cerebral artery, and this intimately lies over the superficial Sylvian vein, and surface branches of SSV, M3 and M4 vessels as shown here. This is the anatomical depiction. One must remember on the surface, there's an outer space. There is no major blood vessels of the middle cerebral artery M1 and M2, only the surface cortical branches. And as you see here, these are the venous communications, superficial venous drainage from the frontal, temporal, and parietal lobes and the drainage of that. The deep auricular compartment extends from lateral Sylvian membrane to auricular cisternal plane as shown here. This is the deeper, second, sorry, I think this is the deeper auricular compartment and contains MCA M2 here, middle cerebral artery, lateral lenticulostriate perforators originating from M2 and superficial and deep middle cerebral veins along with arachnoidal strands connecting vessels and the brain auricula in this space. This is the space that's a deeper auricular space which shows the anatomy M1 and the perforators, that is lateral lenticulostriate perforators. And this is the anatomical dissection. As you go deeper now, you start seeing the middle cerebral artery M2 and the branches as shown here. These are the fibrous strands between the frontal and the temporal lobes, which connect, I'll show you a little later, with each structure inside. And this is the diagrammatic representation of the second space of the Sylvian fissure, that's a deeper space. Third deepest or the cisternal compartment is the most deepest one as shown here, extends from auricular or cisternal plane to medial Sylvian membrane. This is a median Sylvian membrane and lateral cellular cistern. This is the lateral cellular cistern and this contains M1, M2 and ICA bifurcation and anterior cerebral artery A1. The medial compartment or cisternal compartment is very important vital structure and it contains deep middle cerebral vein and MCA M1 proximal perforators. This is anatomical depiction of this. This is the deeper cisternal compartment of middle cerebral artery and the branches and the ICA A1 and M1 and perforators. Along with this, the venous anatomy is of utmost importance in this. Again, type A, the vein drains a major vein, drains both frontal and temporal lobes. Type B drains only the temporal lobe and small tributaries from frontal. And type C, the most common one is type A, 60%, type B, 8%. Type C is the third most common, where it drains in a major trunk separately the frontal and temporal lobes. And type D, the drainage is both from frontal and temporal and goes as one and divides into two. And type E, very, very less common, about 2%. There is no Sylvian vein at all on the surface. It is drains deeper into the basal vein of horizontal and basal venous channels, and surface is drained by the vein of Lebbe and Rolandic vein. Understanding this venous drainage is of utmost importance, more important than the vascular understanding. Now, venous flow from this Sylvian fissure includes, there are 4 types of venous flows. One is superior drainage, which drains superiorly, the vein is pointing up, there is only one vein, drains into Rolandic vein and drains into superior sagittal sinus. Anterior drainage, there is no further veins on the surface and on the temporal parietal region, only one vein goes anteriorly. Posterior drainage, there is only one, that is vein of Lebbe, drains into the transverse sinus. And this is how we understand. Once you open the dura mater, you see the venous pattern and we understand, is this person has the superior drainage, anterior drainage, posterior drainage or mixed drainage, where you see both Rolandic as well as Lebbe and one vein drains in multiple directions. This is more helpful to us, even though there's some damage, the venous drainage continues. This is of utmost importance in understanding. Arachnoidal strands in the Sylvian fissure are important. I'm sure all of us, when we open the Sylvian fissure, we see this strands, artery to artery, artery to brain, artery to vein, brain to brain, and vein to brain. These are the arachnoidal strands bind the brain and structures and vessels, and which by cutting this sharp dissection, we release the Sylvian structures and deeper structures, vessels and nerves and veins. Professor Yassergill is the first time gave the full configuration of this Sylvian fissure, and he gave 4 types of Sylvian fissure anatomically. Type 1, a wide straight Sylvian fissure. Type 2, moderate and wide curved Sylvian fissure or irregular. Type 3, where either the frontal lobe or the temporal lobe herniates with the wide Sylvian fissure. Type 4, narrow Sylvian fissure, and the both frontal and temporal lobes herniate into the Sylvian fissure. So anatomically and surgically, the most helpful to neurosurgeons is the type 1, wide and straight, type 2, wide, little narrower but straight, type 3 and type 4. We need to have a microsurgical technical superiority to dissect these Sylvian fissure ones. Now, coming to the contents of this Sylvian fissure, we have the most important is middle cerebral artery M1, M2, M3, and M4, and branches and perforators, lateral lenticulostriates, and the veins, middle cerebral vein and deeper veins are the most important contents of the Sylvian fissure. The first time in 1980s, Professor Yassergill called this Sylvian fissure highway to the base of the brain or base of the skull. Since then, what we are doing is what he showed us way back in 1980s. This is exactly, once you open the Sylvian fissure, this is exactly the path or the various roads, various communications, various channels you get to access the skull base after opening the Sylvian fissure. It is just for you to make understanding this. What are the structures we can access after we open the Sylvian fissure? We have this much of bony access into the anterior and mid skull base. We have neural, frontal, temporal, and parietal lobes, and the bases of frontal and temporal and parietal lobes. Vascular, we can have complete anterior circulation of the villus. We can access the pituitary gland by this. We can access the cavernous sinus, cranial nerves 1 to 6, hypothalamus, and upper brainstem and midbrain we can access by opening this Sylvian fissure. This is the area on the surface of access. This is on the base where we access. These are the wider area from not only unilateral, you can access the bilateral. And you can go, once you open this in the base of the skull base, you can go front, you can go back, you can go deep medial, you can go behind, and you can go into the opposite side, and you can go the intrahemispheric fissure. These are the locations. Once you enter into this is exactly what happens. Wherever you wish to travel, you can travel in the base of the brain and access important neurovascular structures and various pathologies where we are, as neurosurgeons, are called upon to treat in our day-to-day work. That's the 6 cranial nerves, 1 to 6 you can access. You can access the orbital roof. You can access the cavernous sinus very easily by opening this. So how do we do this? I'll show you a video. Usually majority of the Sylvian fissures, we start from lateral to medial. Only in the middle cerebral aneurysms we start medial to lateral. Arachnoid is open. Now this is what I was mentioning to you, the strands between the brain and brain, vessel and vessel, and vein and vein. You can see the middle cerebral deeper veins. No vein is disturbed. The arachnoid is opened, and you can see the strands there. What we saw graphically, now we are seeing in live. And these are the how we open the Sylvian fissure. Once we open that, we get various corridors, various basal corridor to access. We have interoptic corridor, we have keratico-optic corridor, we have retrocarotid corridor or a door, or we have lamina terminalis corridor. And any of these, we can use them as and when the pathology of the tumor requires during the surgery. These are the various triangles and various arachnoid spaces in the supracellular and paracellular and retrocellular compartments where we can have access to these structures. Over last about 33 years, we have traveled this space almost nearing about 4,000 times, practically every day. I'm sure all neurosurgeons, we practically do this every day. And we give the credit to Professor Yasser for giving us this pathway and making us walk on this very important highway. We have treated more than 3,500 cases, aneurysm nearing about 2,000 AVMs, supracellular meningiomas, craniopharyngiomas, schwannomas, optic pathway gliomas, pituitary adenomas, giant cavernous meningiomas, angiomas, midbrain thalamic, hypothalamic gliomas, deep brain gliomas, supracellular dermoids and epidermoids, and temporal lobe epilepsies are the various lesions. Now I'll take you through our experience, how we do this through this highway and get access. ACOM aneurysm, sometimes post-subarachnoid hemorrhage, the aneurysm is because of subarachnoid hemorrhage, the Sylvian fissure gets filled with the blood. At that time, opening it would be difficult, but we do a small opening here and inject gently the saline. The arachnoid separates from the deeper parts, and you can cut the arachnoid and open the arachnoid well and preserve the Sylvian vessels, arteries, and veins. Now, once you open the Sylvian fissure, now we are getting into the paracellular or supracellular location. The arachnoid medially is opened and supracellular cistern is communicated with the Sylvian fissure. CSF is drained, brain becomes lax. We expose the internal carotid artery, we expose the optic nerve, opposite optic nerve, and here you can see the anterior cerebral artery A1 is exposed, and we take off the lamina terminalis to some extent to relax the brain and to access the A1 medial most part, which prevents us retracting the brain to great extent. That's the A1 which we are exposing, and you can see the recurrent artery of Huebner's, perforators from A1 going back and supplying the basal ganglion on thalamus. You can see the A2 on the opposite side, A1 on the opposite side. Aneurysm neck is very nicely exposed, and without leaving any neck of the aneurysm, you can obliterate the aneurysm completely. That's a A2, A1 on ipsilateral side, lamina terminalis there. We open the lamina terminalis and release the CSF. And this is again to show the students, our trainees, how the location of lamina terminalis and how it is opened. Now aneurysm is obliterated completely with no neck left. And this is the permanent treatment for this aneurysms, and we wrap the aneurysm with a muscle fragment, and that's the patient post-operatively with no neurological deficits on day 2. This is the middle cerebral artery aneurysm. Just now you heard Professor Rene mentioning that we prefer to operate the middle cerebral artery, and again opening the Sylvian fissure wide and deep. Now you can see the aneurysm there, wide and necked aneurysm. You can see the perforators, M1 perforators, that is the lateral ventriculostriates, and that is the ICG, confirms the proximal and distal vessels, dissect the aneurysm from the surroundings, and dissect the complete branches of the M1, and no vessel is kept. Now we can see the ruptured part of the aneurysm. Neck is so widely and so nicely exposed with the high illumination and high magnification with a good microscope. The whole aneurysm is clipped. A permanent treatment, no place for recurrence in these cases. ICG shows a normal distal circulation in these aneurysms, and that's a patient post-operative on day 4 with no neurological deficits. Complex aneurysms, again, you saw just Professor Rene showed them, but surgically we access when they find it difficult. Aneurysms with intracranial hemorrhages, multiple aneurysms, skull-based decompressions, clip reconstructions, trap ligations, and vascular bypasses when it is necessary. This is a large MCA aneurysm which had bled with a hematoma, and this is the indication for surgical intervention. Now, Sylvian Fissure is open medial to lateral. In these cases, we prefer to do that and go following the M1, go distally and expose the aneurysm. It's a big aneurysm. Part of it is dead by bleeding. There is a clot, and part of the aneurysm is still there. And flush with the bifurcation. Clip is applied and ICG is done. And that is the fundus of the aneurysm. And evacuate the clot at the same time after you clip the aneurysm. And the vessels are well preserved. And the patient post-operatively, minimal weakness and walking. Day 10, she goes home. Multiple aneurysms. This lady had 3 aneurysms, DACA, M1, and M2 aneurysms. And DACA had bled. So a big craniotomy, frontotemporal craniotomy. We prefer to cut the fox to maybe 1 to 1.5 inches to create a space in bled aneurysm so that the dissection of proximal anterocerebral artery and distal cerebral anterocerebral artery becomes easy, and you can manipulate the vessel better. Now fox is cut, you can see the anterocerebral artery there, and this again looks like a bilobed aneurysm. Aneurysm is dissected well, and you can see the DACAs, both the DACAs and aneurysm is seen. It has 2 lobes, one here and one posteriorly, and you need to do 2 clips. One, the part which was ruptured is clipped, and the second lobe, which is posteriorly placed and which is not ruptured, is again obliterated completely. Now, once we do that, the ruptured aneurysm, the same craniotomy, the Sylvian fissure is opened medial to lateral, and we access M1, and you can see the aneurysm originating from the M1, and there the major lenticulostriate taking origin from the M1 there, and that is dissected, understood, and seen and preserved, and that only it is at the bifurcation of the lenticulostriates, which needs to preserve under any circumstances. If you damage this, patient will wake up with the hemiplegia because it supplies caudate nucleus, basal ganglion, and internal capsule. Now the perforator is separated, and a curved clip in configuration with the M1 is used. Gently flush with the parent vessel, clip the aneurysm, and that becomes a permanent obliteration of the aneurysm, and you can see a complete block. Now you go distally, and the third aneurysm is at the bifurcation of M1, and that is M2 aneurysm. You can see the bifurcation, wide neck, and easy to clip. We cannot rupture. Dissect on both sides, 360 degrees. See all the perforators and vessels around it, and gently obliterate the aneurysm. And that is the post-operative patient on day 3, no neurological deficits and complete obliteration of the aneurysm. So these are multiple aneurysms. And clip reconstruction, sometimes you are needed when someone asked about the blister or the fusiform aneurysm is again an indication here. A large ICA aneurysm presented with a bleed. You can see the whole ICA is become an aneurysm. Posterior wall is dilated to become an aneurysm here. The proximal ICA is exposed and kept for proximal control, and the surface is dissected. Now you can see the bifurcation here, and that is the aneurysmal wall. ICG shows the proximal neck and the distal neck. Now that's a distal neck, and that's a fusiform dilatation. Now you use a fenestrated clip. We need to reconstruct the vessel here, and this is just like using the flow diverter inside. We are using it outside. Now the aneurysm is obliterated here, and the part of the neck here, if you dissect again, see the part of the neck is still preserved there. Again, we need to use one more clip to use it and clip it again and obliterate the neck. And when we again inspect, we feel that small part of the aneurysm is still there, and put one more fenestrated clip and obliterate. So this is a complete comprehensive clipping, and these aneurysms, they don't grow at all in future. What's the risk of endovascular procedure, this always gives us that risk in many of the cases. This is a comprehensive clipping. That's a postoperative angiogram, shows no aneurysm, and that's a patient postoperatively without any neurological deficits. This is a large IC aneurysm. Just now, Professor asked a question that when the vessel, the aneurysmal dilatation occurs, now we need to reconstruct the aneurysm here. You can see the ICA is originating from the aneurysm, and proximal ICA is become aneurysm presented to the vision important. Now, first we expose the neck, have a proximal control, and distally we expose and put a clip proximally and distally and control the aneurysm, and take a long clip and in between the space obliterate. In these cases, we need to use multiple clips so that one clip on a carotid artery, because of the pressure, will push away the clip in future and again regrow. So 3 clips are used and complete obliteration, and there's a patient postoperatively with no neurological deficits, and there's a scan, CT angio 128 slice showing complete obliteration. Just now, Professor Shah asked a question that if there is an aneurysm originating from the neck of the aneurysm, posterior communicating artery is originating, and it's a dominant posterior communicating artery, and this needs to be preserved under any circumstances. Again, trans-Sylvian, and we have opened the Sylvian fissure wide. That's an ICA, and that is the big aneurysm there. We have proximal control, and that's a posterior communicating artery taking origin from the neck of the aneurysm. And now we put a temporary clip on the ICA, and now put a long distal clip also, and put a long clip on the aneurysm and obliterate both posterior communicating as well as the aneurysm. Now what happens is you open the clip, and gently the proximal clip is withdrawn about 1 millimeter towards our side, and that opens up the posterior communicating artery. So this is the clip reconstruction technique where we can preserve the vessel, and that's a patient postoperatively on day 2 with no neurological deficits and normally maintained distal circulation. Large carotico-ophthalmic aneurysms here. You can see the big aneurysm where we need to do the decompression of the skull base. We use of late bone CUSA to do the decompression of anteroclinoid and the carotid canal, and proximal carotid ring and distal carotid ring are exposed. That's the proximal neck, and that's a distal neck. Again, flush with the aneurysm of the ICA. Aneurysm is clipped, reinforcing clips are placed, and there is a small bleb of aneurysm left there, the mother aneurysm. We take a small clip and obliterate that also. This is the advantage of surgical obliteration, probably as Professor Mathuria mentioned, is complete obliteration. And again, Professor Chapo also mentioned that the regrowth chances are very less. This I'll skip again. It's an ICH with the aneurysm. Now, MCA aneurysm, again with the ICH, I'll skip this aneurysm. A large giant aneurysm, again, a very complicated issue. Our endovascular procedure, people said we cannot do that. Now, because you see the huge aneurysm, or the dilatation of ICA itself, and the distal ICA, this giving rise to originating from the dome of the aneurysm, and M1 and A1 are originating from this, and PCA again originating from this. This we plan to do the balloon occlusion test. Just now we heard Professor Chapo mentioning it. It is extremely important to have a balloon occlusion test to see the patency of circulation and cross circulation. Now that's a balloon occlusion test shows the aneurysm is filling from the opposite side too. And now what is happening here, if you look at it, the opposite side circulation is patent, and aneurysm is, the opposite circulation is filling well. Here, you can see the opposite injection and balloon occlusion here. The opposite circulation is filling very well, but the circulation is very slow, suggestive of patient may have problem if we sacrifice the ICA, that is the parent vessel sacrifice. Now, what we did is first we did a proximal control in the neck and expose the neck. Then we did superficial temporal to M2 bypass, and the revascularization was done. Then this is what the plan of surgery. We open the Sylvian fissure and put the clamp in the neck on ICA is blocked, and the aneurysm becomes less. Now dissect the aneurysm distal part. What you are seeing on the aneurysm neck, you can see the posterior communicating artery, anterior artery. Proximal to posterior communicating artery, we clip the aneurysm completely, and the whole aneurysm is taken away from the circulation. And this is the diagrammatic representation. This is a patient on day 7. He had a minimal weakness on the right side, but subsequently recovered without any residual. Now coming to the arteriovenous malformations, a lady presented with the hemorrhage, medial temporal hemorrhage with the AV malformation with the bleed. The Sylvian fissure is opened, and the M1 and A1 and ICA are exposed, and the medial temporal region is exposed. The AVM is getting blood supply from the perforators. It is getting blood supply from the anterior choroidal, and it is getting blood supply from the posterior communicating artery. All these branches are coagulated, and the nidus is excised. Medial part of the temporal lobe, you can see the posterior communicating artery there, and complete excision of the AV malformation. And that's a patient post-operatively with minimal weakness on the right side, which recovered completely. Sylvian fissure, medial temporal cavernous angioma with a bleed. You can see here a big cavernous malformation. This was done through navigation control, navigation guidance. A frontotemporal craniotomy, locating the angioma on the surface, and corresponding craniotomy is planned. Pterional craniotomy, dura is opened again on the surface. The angioma is marked. Access is planned. Sylvian fissure is opened, deep and wide. Medial temporal region, according to navigation guidance, the angioma is located very quickly and very easily. Now you see the dissection of the angioma, the blood clot inside is evacuated, and gently the capsule is held, and the angioma is dissected from the medial temporal region completely without disturbing the middle cerebral artery and the lateral lenticulostriates at M1 perforators, and complete excision of the angioma is done under high illumination and high magnification, and that's the end of surgery. The whole angioma is taken out. At the end of surgery, you can see the MCA, M1, M2 perforators going deeper to the angioma are very well preserved without any damage. And this is the end stage of surgery. Well preserved middle cerebral branches, intraoperative navigation, confirming the complete excision, post-operative CT, and that is the patient post-operatively with no neurological deficits on day 3. Skull-based tumors, very commonly we are called upon, craniopharyngiomas. Here, dissection from the skull base in craniopharyngiomas, perforator preservation, and pituitary stalk preservation we can achieve with this trans-Sylvian approach. 3-corridor approach, that is interoptic approach, a big craniopharyngioma, first decompressed through the interoptic route. Then we open the keratico-optic corridor and debulk the tumor, the posterior part of the tumor. Next, decompress and dissect from superior part of the tumor and the basal part of the tumor, and go posteriorly, that is retrocarotid space, and take off the lesion completely. Now you see the pituitary stalk is seen well, and part of the tumor which is adherent to the pituitary stalk. Very rarely, it's very uncommon to excise the tumor from the stalk many times in craniopharyngiomas, but we should always try to do that. That's a last stage of the tumor originating from the pituitary stalk, taken out completely in between the keratico-optic corridor, and well preserved the vessels, the posterior communicating artery on the opposite side, choroidal arteries, optic nerves, optic chiasm, and complete excision of the lesion. And that's the scan post-operatively, complete removal of the lesion. and that is the complete excision. Next, sometimes we are called upon to treat the tumor from the circle of Willis, where the lesion encases or encircles the circle of Willis. We need to dissect. At that time, we need to go through transsylvian, and you can see the M1 ICA bifurcation and the lateral lenticulostriates, medial lenticulostriates. The whole tumor is in between these vessels, and this was operated 3 times. 2 times we are doing it for the last time. Third time we had to do exercise completely young girl, and with the whole life in front of her. Already in last about 5 years, she had 2 surgeries. So we went ahead and excised completely transsylvian route microsurgically. Almost whole tumor is taken out and subjected for radiation for a small remnant tumor in this case, and she is doing perfectly well. We did it almost about 10 years back, 9 years back. Now she is studying in the college with minimal weakness on the left side. Right side, she has weakness, and she is doing very well. Perforator preservation again is possible in these cases. As you see here, prefixed chiasm, and we cannot enter there. Now we open the keratico-optic space and separate the arachnoid and dissect the tumor completely in between these 2 spaces and take off the tumor. Then go behind the carotid. That's a retrocarotid approach. You can see the illumination and magnification, which will prevent the injury to the vessels. Most important here. Now the posterior part of the tumor, which is here, is being dissected. Now you can see the A1 and M1 perforators, so beautifully shown, going lenticulostriates, and you can go in between these perforators gently and excise the tumor completely and achieve the complete excision here as shown. Now that's in between the perforators, you can go and gently you can, once the tumor is debulked, these perforators, they get relaxed and you can access the tumor in between slowly under high illumination and high magnification. That's a tumor removed completely, and that's a patient post-operatively with no neurological deficits. Now coming to the large pituitary tumors, pituitary stalk preservation in case of craniopharyngiomas, what we always try to do. Again, frontotemporal pterional craniotomy. I'll go a little faster, and multiple corridors, intraoptic corridor, keratico-optic corridor, complete debulking the tumor. That's ICA and M1, A1, and the tumor is taken out, all the 3 spaces, and this is the anteriorly to the carotid artery, and you can remove the lesion completely. The whole tumor is taken out from all the 3 corridors, and you can see the removal, last bit is removed, and the liliquist membrane is well preserved. Basilar artery, basilar bifurcation, you can see through the space, and that's a pituitary stalk, very well preserved in this case, even though the tumor is large. Post-op MRI shows well preserved pituitary stalk and complete excision of the lesion. Now coming to the tumors, giant pituitary adenomas, sometimes we are called upon to treat transcranially because they involve multiple compartments. We prefer to do fronto-orbito-zygomatico-temporal craniotomy. Opening the Sylvian fissure again is a boon to us. First, access the lesion. You can see the widened, thinned, and spread the optic nerve, and in between the optic nerve, both the optic nerves, the intra-optic approach, we can access the lesion and debulk the lesion from there, and go behind the optic nerve and debulk the tumor completely and dissect it from the retro keratico-optic space and debulk the tumor and reduce it in size and decompress the optic nerves and optic chiasm. Now this is the part of the tumor which is involving the cavernous sinus, lateral wall of the cavernous sinus. The capsule is opened and the tumor is decompressed from the lateral wall of the cavernous sinus going inside. Now you can see the tumor going into the basal part, originating from the sella Again, that part also is debulked, and through the curved suction, all the localities of the suprasellar region are taken out. Now, at this juncture, we bring in the endoscope and see the remnant tumor if there is anything, and excise it, because microscope fails to show the tumor which is in the superior compartment and posterior compartment. We can, with the endoscope help, we can excise. You can see the A1, M1, and complete removal of the tumor here, and that's the patient post-operatively. She had a ptosis on the right side, opposite side, subsequently, but vision was very well preserved. Even that eye, only the third nerve was, before the surgery, she had bled, and that's a patient post-operatively without no neurological deficits. Now, coming to the meningiomas, skull-based meningiomas, that's tuberculum cellae meningiomas, planum sphenoidal, suprasellar meningiomas, and cavernous sinus meningiomas. I think we are short of time. I'll not show all these cases. Only one case I'll show. The aims of these meningiomas includes Simpson's type 1 excision, preservation of optic nerves and optic chiasm, and preservation of 1 to 6 cranial nerves, preservation of pituitary stalk, preservation of circle of Willis and perforators and hypothalamus are the aims when you try to treat this tuberculum cellae meningiomas. A large tuberculum cellae meningioma coming with the visual involvement. Again, pterional craniotomy, you can access the lesion very well, and we prefer to do the free bone flap. Dura mater is opened with the base towards the skull base. Sylvian fissure is opened, and M1 is followed. Go to the base, origin of the tumor from the tuberculum cellae region, and internal debulking of the tumor is done. And you can see how much space we get by opening the Sylvian fissure, become very safe and comfortable. Once you do the debulking of the tumor significantly, the capsule starts separating from the basal frontal region, and you keep dissecting and excising without touching the brain. We can take off the lesion completely, and the brain is not, any part of the brain, vessels, veins, arteries, and brain is not touched at all with this access. The capsule is taken off completely. At the end, you see the opposite carotid artery, and this is the origin of the tumor. Always try to do Simpson's type 1 excision along with the dura mater. Now you can see the carotid artery opposite side, A1, A2, anterior communicating artery, and the lesion is removed completely. Optic nerves on both sides, elevated flattened chiasm. That's a pituitary stalk. In many of these lesions, you can preserve the stalk. You can see the vessels, recurrent artery of Hubner, and that's the end stage of surgery, and patient with no deficits at all. Her vision has improved completely, and she can see normally. This is an advantage of this trans-Sylvian approach. I think these are all the same ones, the complete excision of the dura, type 1 Simpson's excision, and this is the dissection of the meningioma from the circle of Willis, preservation of circle of Willis we saw just now. That's the A1 perforators, that is the medial lenticulostriates are preserved with the recurrent artery of Hubner. The preservation, again, it is done through trans-Sylvian wide opening of Sylvian fissure. The superior part of the capsule, you can see the preservation of both the anterior cerebral arteries, optic nerve, both the distal ACAs, anterior communicating artery, and complete excision of the lesion. When the tumor, this is when the tumor goes into the optic canal, we decompress the anterior clinoid and expose the optic nerve. Go inside the canal through the opening, and what the part of the tumor, about 13 to 18% of these tumors go into the optic foramen and optic canal. And if you don't decompress this, patient's vision will not improve. Again, this we can achieve it only going trans-Sylvian route and decompress the optic canal and excise the lesion inside the optic foramen and optic canal and take out the lesion. Again, we bring in the endoscope and see the complete excision inside the optic canal, posterior to the optic nerve, where microscope will fail us to see. I think I'll skip this one. Again, the similar procedure, cavernous sinus meningioma, these videos are there. Now coming to the deep brain gliomas, again, this is a very important axis. Gangliocapsular glioma in a young girl, you can see the large lesion there in the basal ganglion and internal capsule. She came with a bleed. We thought it could be an vascular pathology. We did an angiogram, which was normal. Again, we accessed it through the pterional craniotomy. This is the craniotomy. Well, it's not playing. Video is not playing. It's something I'll leave it to a lot waste of time. This is midbrain thalamic glioma. Again, a younger boy came with the glioma involving the midbrain crest and going up into the thalamus. Again, there is no way of accessing this lesion. Lesion is on the left side. We cannot access this. And this is the DTA showing the tumor splaying the important tracts. This is a corticospinal tract and connecting fibers, optic radiations, splaying. And this gave us a very important thing. Then with the navigation guidance, we planned the craniotomy and access to the tumor through Sylvian fissure. The skull base is drilled and the tumor is accessed. This is the drilling of the medial sphenoidal wing. Navigation gives us the access, the road to this. Again, Sylvian fissure is open, deep and wide as shown here, and go medially. Once you go medially, the posterior tract is followed, and you can see the tumor bulge there coming into the posterior part of the Sylvian fissure. The capsule is opened and internal debulking is done. Every stage we keep navigating to see where we are. And that is the internal part of the tumor is basal part of the tumor debulked. You can say third nerve there. And you can say posterior cerebral artery, internal carotid artery, posterior communicating artery, and choroidal artery. Now we are going superiorly, which the part of the tumor going into the thalamus, thalamic region, that needs to be taken out. Now you can see, we can access that part of the tumor also, opening the arachnoid, and you can see the supracellular structures very well. And you can see the posterior cerebral artery, and that is the ambient system. And that's a tumor going superiorly into the thalamus. Again, we keep navigating. There may be some amount of brain shift, but that is to the extent of 1 to 2 millimeters. But where you are actually is of great help during the surgery. By navigation, we can be a little more safer. Superior part of the tumor going into the thalamus is pulled down and taken out completely as shown here. The complete excision is done, and you can see the superior most part and posterior part of the tumor is being removed. That's a posterior cerebral artery, and that is the midbrain and opposite side of the crus. Absolute hemostasis is achieved. End stage of surgery. ICA, PCOM, third nerve, and anterofemoral artery, optic nerve are very well preserved. Again, bring in the endoscope, see the extent of resection, and if there is any remnant tumor there, you can excise that also. End stage of surgery, and bone flap is replaced and fixed. That's a patient post-operatively had weakness on the right side, but recovered subsequently. It was grade 3 astrocytoma we are subjecting for radiation. Well, I think that's the last video. I think I'll stop at that. So Sylvian fissure is a natural, convenient, comfortable, safe access to the skull base, vital neurovascular structures. Detailed anatomical, physiological knowledge is a must for all the neurosurgeons. And Professor Yasser Gill always mentions, if you don't know how to work on Sylvian fissure, how to open the Sylvian fissure, you cannot become a microneurosurgeon, you cannot become an aneurysm surgeon, you cannot become a skull-based surgeon. It's a mandatory for neurosurgeons to do these complex procedures. Greatly helps in comprehensive management of critical neurosurgical pathologies, vastly reduces the morbidities and mortalities. And thank you very much. Probably that's the last slide. Thank you very much.
Thank you very much, Professor Suresh, for this comprehensive and detailed anatomy, and also for the great cases you presented. how to deal with various pathologies through the Sylvian Fissure, the amount of cases in different pathologies show how meticulous microsurgical techniques is very important to safely treat patients and get the best results without complication and without morbidity and mortality. Thank you very much, Professor Suresh. Any questions?
There's no question in the box. Probably I may ask one question, Professor. Thanks for a very excellent presentation with multiple pathologies. I would like to ask Professor, because for skull base, the signboard towards direction is always vessels, and Professor has shown us a vessel which directed us to many locations. And at the same time, in doing surgery, we try to avoid manipulation of the vessel, as it can cause a lot of vascular problems such as venous thrombosis, infarction. So may I ask Professor, what is the best surgical method, microvascular micro dissection method that for us to assess the location at the same time preservation of vessels as much as possible, less manipulation of those vessels? Thank you, Professor.
Yeah, thank you, Professor Bolsing. It's a very important and very practical problem. Each one of us keeps doing it every day. The only issue here is once you know that you are going into the skull base, you are going to deal with middle cerebral artery. You are going to deal with circle of Willis. Mentally, you are prepared. You are going to see this is a vascular area, be it aneurysms or be it tumors. You are going through this. So you have to, as a neurosurgeon, you have to be extremely delicate and extremely slow. When you're absolutely right. See, the tumor is there, the subarachnoid hemorrhage is there, aneurysm is there, AVM is there. You touch these vessels, they go into spasm. You touch the vein, they go into spasm. So the best option would be to be very gentle, open the arachnoids, cut the arachnoidal bands, cut the fibers, the arachnoidal fibers, relax the vessels and push them away from your field as much as possible. Sometimes, as you see in meningiomas, pituitaries, craniopharyngiomas, they are all in your way. They are all in your way. So the high illumination, high magnification, dissection under this with a sharp dissection, probably another added factor which helps us to damage less or manipulate less these vessels and try to push them away and separate them. And most important, your very important question, what you have point, I would like to mention to the younger generation who are looking at, keep your suction very low, suction power. Keep your bipolar intensity very low. And use a bipolar as a dissector, sharp dissector. Suction, gentle suction as sharp dissector. Use cottons whenever necessary. And keep washing repeatedly the subarachnoid space in blood vessels. And we prefer to wash repeatedly we mix the papaverine in the saline from the beginning of the surgery. So we keep washing. Many times what happens is pituitary tumors, the material of the pituitary tumor, the material which comes out of the pituitary tumor is a chemically active tumor, active material. This, when it comes in contact with the blood vessels, it can cause vasospasm. The craniopharyngioma fluid, the craniopharyngioma contents, when they come out and engulf the vessel, they may cause vasospasm. And there may be some amount of blood. Some surgical handling also cause vasospasm. So this keep every phase, keep washing, keep the area clean. These are the few tips which help us to prevent the injury to the. I very much agree with you. In these cases, the surgical outcome is directly proportionate to the vessels you handle, veins as well as nerves. So as you keep doing, you keep improving ourselves and keep learning ourselves. That's what I feel.
Thank you, Professor.
Thank you.
There's a question in the chat box
Yes.
by Professor Eidman asking that when will you use the orbital zygomatic approach from your experience?
Yes, thank you. Again, a very important question. All pituitary tumors, cavernous sinus meningiomas, and skull-based meningiomas, we prefer to use and orbital meningiomas, intraorbital meningiomas, and trigeminal schwannomas, dumbbell schwannomas, where part of the tumor is paracavernous in the middle cranial fossa, part is behind. We prefer to do the fronto, orbito, zygomatico, sometimes temporal. Fronto, orbito, zygomatico, temporal. And we prefer to take out the whole thing in one piece, one bone. We don't prefer to make two sections. We take it as one piece, and so that we fix it very well with one piece. These are the few pathologies would do it. And number two, sometimes this optic chiasmatic gliomas, optic neurogliomas, optic chiasmatic gliomas, we prefer to do this fronto-orbital zygomatico temporal cranial.
Yeah, thank you, Professor. There's another question from the same doctor.
Yes.
Asking regarding whether you use a loop or microscope for dissection of Sylvian fissure.
Sorry?
Which one you prefer, loops or microscope for dissection of Sylvian fissure?
Yeah, thank you. Again, it's an important question. We always prefer a microscope.
Okay.
Always. We prefer a microscope. It is better. A good microscope makes your life very simple, comfortable, and safe to the patient. Loops you can use, but not very, not advisable, rather. Yeah. If you go to a place where there is no microscope, well, you can use it, but preferably microscope, a good microscope with a beam splitter and high magnification illumination and the resolution, preferably. These are the best ones because you are handling the vessels of the brain. You may take out the tumor completely, but patient wakes up with hemiparesis, hemiplegia, vision loss, who have not achieved anything. Our aim as neurosurgeons, when the patient walks into the OT, he should walk out in the same condition. We should not be causing the further problem than already the patient has. That should be our aim when you go inside. And for that, we should not compromise. In any way, we should not come.
Probably back to Professor Wasim. Professor?
Yeah, I think as Professor Suresh mentioned, that low power suction is very important in this situation because if you use high power suction, it's very dangerous. And this is, I think this is the best advice for today. It's a take-home message: use low bipolar and low power suction because this is very important. And I think Professor Suresh elaborated everything, and I love these videos, and I think it's very important to learn how to use the microscope in dissecting Sylvian fissure and to do it meticulously, slowly, and avoid the veins, avoid compromising arteries, of course. And in tumors, you have to be slow, preserve arteries, because this is a very, very important blood supply to the brain. If you compromise arteries, you will have troubles. And in case of complications, you have to be ready for complications. So I want to ask Professor Suresh, how you prepare yourself for a complication, how you prepare yourself for in one of your surgeries, what you do.
Sorry, question? Can you repeat the question?
When you have a complication, what advice you give to the young neurosurgeons?
Yes, most important. Thank you, Professor Wasim. It is a very important point. During surgery, is not important. Anticipating and avoiding the problem complications is very important. Again, as I mentioned to you earlier, before surgery starts, your complication avoidance starts before surgery. Have a study of the scan or angiogram one night before and visualize your access, your approach, your dissections, everything beforehand, one day before. This is my plan of doing the surgery, and try to stick to that plan and try to do it, number one. Number two, each problem, each pathology has a different complications. Like you are dealing with craniopharyngioma, we have different complication. You are dealing with meningioma, we have different complication. We are dealing with aneurysms, we have different complications. We are dealing with pituitary tumors, we have different complications. So what we are dealing with, what are the complications we anticipate, divide. Next important is always, as I mentioned to you just now, be very gentle, good and wide exposure. Don't try to do in a very small and narrow field of big lesions. Good exposure, wide exposure. Open the arachnoid very well. Separate the vessels from the nerves and vessels from the thing. And do it with a good focus of the microscope, high illumination and high magnification. And try to identify and separate the lesions. And as I mentioned to you earlier, use bipolar and section very less. Anticipate the problem and dissect all around. Preserve the perforators of the M1 and A1. This is the most important factor in any surgery on the anterior skull base, preservation of perforators. Recurrent artery of Huebner's when you are doing the aneurysm surgery, anterior communicating artery or A1, A2 segments or MCA perforators. So see all these structures slowly, meticulously and gently. If you do, many times you will avoid the complications. And I personally, one good advice to the younger generation, the most what you call philosophical advice is that treat patient as your relative. He is my relative. Come what may, I'll not harm him. So every patient is my relative. I'll not harm him. If you have that concept in mind, go meticulously with wide open mind and dissect. You will do very well. And God will be on our side.
Now I am on the line. Can I make a comment?
Yes, sir. Please, sir.
Yes, Suresh.
Sir, he is my teacher. I forgot to mention. We learned neurosurgery from Mathurya, sir, all the time. He is a Bhishma of neurosurgery in our country. And he has trained, like me, thousands and thousands of neurosurgeons in his career of 45 years as a neurosurgeon. One of the most premier neurosurgical institutes in the country, or I would say in Asia. That is Postgraduate Institute of Medical Sciences and Research. I'm sure all of you have heard. PGI Chandigarh. He is a director, a professor, HOD, and dean of PGI Chandigarh, from whom we keep learned. Still we keep learning from him. Thank you very much, sir. Please go ahead.
Thank you.
Thank you.
There are 2-3 things when I think that I was not heard in the aneurysms. One thing I'll tell you, there is no aneurysm on the earth which cannot be clipped by Dr. Hirotoshi Sano from Fujita, Japan.
I agree with you, sir. I agree with you.
And number two, the comment in your talk is, see, all lesions in the skull base when you are going to approach, it is already been pointed out by the chairman that you should do a frontotemporal-orbitozygomatic craniotomy.
Yes.
If these are the skull lesions, number one. And number two, wider the exposure opening of the Sylvian fissure, lesser is the retraction and better is the visualization, and least are the complications.
True, sir.
Two.
True.
And third is, try to utilize the maximum magnification in the Sylvian fissure. When you are opening the Sylvian fissure, use the maximum possible magnification. That is how it has been pointed out about the vessels and all. the morphology you will be able to see very nicely with highest magnification. 3.
Very
The
good, sir.
4th is never ever apply a retractor when you are opening a Sylvian fissure.
True, sir. True.
You can do it subsequently.
Yes.
And now there is one question, Suresh.
Yes, sir.
If there are vessels which are seen to you, which have become narrowed because of the retraction and dissection,
Yes.
will you like to put piperine on that?
Yes, sir. First thing, as I very much agree, what we learned from you, the retraction should be, again, I forgot to mention, I'm sorry, the less the retraction, better for the during any part of surgery. And retraction happens only when you need a bimanual dissection, where you need to use both the hands simultaneously. That time you can put the retractor, number 1. Number 2, when the sir asked the question when the perforators or small vessels go into spasm, at that time your possibilities are, 1, that you have put a more what you call a pressure, retractant pressure is high, number 1. Number 2, your suction pressure is high. You're sucked directly on these vessels. Number 3, there is a sauerkraut hemorrhage inside the fissure or surrounding areas that needs to be understood and that needs to be cleaned. If none of these things are happening there, we can use first wash it with the saline and wash it with the piperine saline if the spasm still remains. That's what we do.
Thank you very much. So nice.
Thank you, sir. Thank you.
Okay,
Wasim?
Dr.
So I think, thank you very much, Professor Suresh, for this amazing talk. And I would like to hand to Professor Bom Liu for concluding the session today.
Thank you for Professor Suresh again for
Thank you.
excellent talk, and Professor Wasim for chairing this session. We close this session on behalf of Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both speakers today, Professor Reni Chapot and Professor Suresh Dugadi, and also chairs Professor Anil Karapuka and also Professor Wasim Aziz for the time and support for the ACNS webinar. A special thank to Professor Zubin for broadcasting this webinar on WeChat channel. Till we meet again tomorrow, it's bye-bye from all us. Thank you, Professor.